Hey everyone, let's dive right into today's explainer. We are going to completely shatter some widespread misconceptions and decode the deep biological mechanisms driving atopic dermatitis. Far too often this condition just gets brushed off as, a little bit of dry skin, but actually, scratch that, it is so much more complex. We're going to dig into the hard science, explore some absolutely crucial clinical diagnostic tools, and uncover incredible new patient care perspectives that are, quite frankly, changing lives. So, let's get right into it. Let's start by anchoring this in the real patient experience. Imagine losing 1 to 2 hours of sleep every single night. Well, for a staggering 60 to 80% of patients with moderate to severe atopic dermatitis, that is their nightly reality during flares. Just think about the compounding toll that takes on a person's cognitive function, their mood, their whole quality of life. This isn't just an itch, it is a massive systemic disruptor. And to really put that into perspective, just look at the Dermatology Life Quality Index, or DLQI. The burden in severe atopic dermatitis literally matches conditions we universally recognize as life-altering. We're talking heart failure and cancer. This really highlights the profound psychosocial burden of the disease. It proves once and for all that we are dealing with a severe, systemic condition that demands serious medical attention. Okay, here's our agenda for today's explainer. 1. The real patient burden. 2. The double-hit biology. 3. The psoriasis trap. And 4. New eras in patient care. Section 1. The real patient burden. So to really understand the true systemic nature of atopic dermatitis, we have to look beyond just the skin and see how this evolves over a patient's lifetime. It turns out it's often just the beginning of a fascinating progression known in the medical community as the atopic march. It's kind of like a domino effect. The skin barrier failure in infancy actually acts as the entry point for a lifetime of allergic diseases. Environmental and food allergens penetrate that broken skin, causing systemic sensitization. That's exactly why 50 to 70% of kids with moderate to severe AD will eventually develop conditions like asthma or allergic rhinitis as they grow up. Moving right along to Section 2, the double-hit biology. If we look under the microscope, the current scientific consensus reveals this fascinating bidirectional interplay. It's essentially a double hit, a broken physical wall combined with an overactive immune alarm. This structurally compromised outer layer, the stratum corneum, isn't just dry, it is biologically defective. For 20 to 30% of Western patients, this starts with genetic mutations in the FLG gene, halting the production of a crucial structural protein called filaggrin. Throw in severely reduced ceramide levels and the overactivation of serine proteases that are literally chewing up the connections between skin cells, and what do you get? A barrier that causes massive water loss and leaves the body totally defenseless against outside irritants. And when that physical barrier breaks down, the microbiome goes totally out of whack. I mean, healthy skin has a wonderfully diverse community of bacteria, but in atopic dermatitis, Staphylococcus aureus essentially takes over, colonizing a whopping 90% of skin lesions. And it's not just sitting there passively either. Staph aureus produces its own proteases that actively destroy the skin barrier even further, while its toxins trigger massive immune and allergic responses. That barrier damage leads directly to the second half of our double-hit biology, the T2 immune storm. Stressed skin cells literally scream for help using alarmins like TSLP and IL-33. This unleashes inflammatory signals like IL-4 and IL-13. And here is the specific culprit for the itch, a signal called IL-31 that directly triggers itch neurons. This immune dysregulation is what drives that unbearable midnight itch. And because standard antihistamines don't effectively block these specific signals, patients are left trapped in this vicious itch-scratch cycle that physically destroys whatever is left of their barrier. Section 3. The psoriasis track. Now, getting the clinical diagnosis right is notoriously tricky in everyday practice. Clinicians have to hunt for very specific signs. Spongiosis, for example, is the histological hallmark of the active acute phases of atopic dermatitis. It's essentially fluid building up between the cells in the epidermis, manifesting clinically as weeping, crusted, and highly inflamed skin lesions. This is the disease in its highly active acute state. But over time, all that intense scratching literally changes the skin's architecture. This leads to lichenification, a chronic thickening of the skin with deep, accentuated lines. It's basically a defense mechanism by the skin, and you see it predominantly in adult lesions. But here's the catch. This chronic thickening is exactly what leads to severe diagnostic confusion with our next major topic, psoriatic plaques.
So, this brings up a huge question. Have you been misdiagnosed? With misdiagnosis rates estimated between 15 to 30% in primary care, it's absolutely something every chronic skin patient needs to ask. Many patients who are told they have eczema might actually have psoriasis, or, incredibly, they might have both simultaneously. And getting this wrong, well, it means the treatments just won't work.
Understanding the nuances between these two is a vital clinical tool. If your lesions are in the flexural surfaces, like the creases of your elbows or knees with poorly defined borders and an unbearable sleep-disrupting itch, that strongly points to atopic dermatitis. But if the lesions sit on extensor surfaces, like the outer elbows, and they have sharp, well-defined borders with a thick, silvery scale, that is classic psoriasis. Nailing down these differences is absolutely critical to unlocking the right treatment pathway. Section 4. New eras in patient care. Getting that precise clinical diagnostic clarity is a total game changer because modern pharmacological breakthroughs have completely revolutionized how we target these specific biological mechanisms. But before we get into the newest therapies, we can't skip the foundation of patient care, locking in moisture and repairing that physical wall before a flare even happens. Step 1 is a heavy, generous application of ceramide-dominant emollients to replace those missing lipids. Step 2 requires strict trigger management, identifying specific allergens and, crucially, managing sweat, which is a massive trigger for ADH. Finally, Step 3 involves using proactive topical anti-inflammatories intermittently just to prevent flares from taking hold. From moderate to severe cases, welcome to the biologic revolution. Instead of suppressing the entire immune system, these targeted biologic therapies act like smart missiles. Dupilumab blocks the shared receptor for IL-4 and IL-13, basically shutting off the main engine of the Th2 inflammation. Tralokinumab targets IL-13 specifically, and nemolizumab goes directly after that IL-31 receptor, offering a rapid, dramatic reduction in that unbearable itch we were talking about earlier. This is precision medicine at its absolute finest. Beyond biologics, oral JAK inhibitors are making huge waves. Medications like upadacitinib and abrocitinib block multiple inflammatory cytokine pathways simultaneously from inside the cell. The result? An incredibly rapid shutdown of those inflammatory signals, often providing severe itch relief within just a matter of days. Now, while these do require a very careful risk-benefit discussion with your doctor due to potential systemic side effects, they represent an incredibly powerful tool for patients suffering from relentless symptoms. But hey, true patient care means treating the whole person, right? Not just a single molecular pathway. Integrating supportive approaches is essential. Things like dilute bleach baths can actively fight off that Staph aureus colonization. Vitamin D supplementation supports the genetics of your skin barrier, while omega-3s can help shift immune dominance. And perhaps most importantly, routine mental health screening. Because of the sleep loss, the chronic itch, and the social stigma, depression and anxiety are remarkably prevalent here. We have to address the psychological side just as much as the physical. We've covered the staggering burden, the fascinating biology, the clinical diagnostic traps, and the incredible new treatments. I really hope this explainer empowers you to advocate for your own diagnostic clarity and to take full advantage of this incredible new era of targeted medical care. So I'll leave you with this final thought to bring up with your healthcare provider. Does your clinical diagnosis truly match your unique symptoms? And are you getting the modern, targeted relief you absolutely deserve? Thanks so much for learning with me today, and keep asking the right questions.